Let's continue our discussion today with recurrent ovarian cancer. Unfortunately, most patients diagnosed with advanced ovarian cancer recur and ultimately get many lines of therapy. I'm happy to say that although the number of ovarian cancer cases is actually decreasing, that the prevalence is increasing. So what that probably means is that patients are living longer, and I think the SEER database has told us that. And it's probably related to these targeted agents that we're talking about, and also just better clinical care. So Jubilee, tell us though how the kind of the goals of therapy change from frontline to recurrent disease.
Sure. I think, Tom, you alluded to that before, actually, that it's not just about overall survival anymore. And some of this is really about how patients tolerate therapy, in addition to getting as much as you can out of every single treatment in terms of additive PFS and in terms of quality of life. So when we look at this, we have to look at strategies for quality of life as well as outcomes.
What I tell my patients, live longer and better.
Exactly.
It used to be we just had to help them live longer, but that's not acceptable anymore.
Exactly. And now I think we're seeing things, we're seeing a lot of data where we can pick the singlet or doublet in chemotherapy, and we can add either PARP or Bev to that. Right. And it's the strategy of finding which of those therapies gives the patient the best outcome.
Right. So we used to talk about platinum resistant and platinum sensitive. We've actually tried to get away from those, and Tom, you've been a great teacher in messaging that. Tell me how we're getting away from this platinum sensitive, platinum resistant definition, what the new terminology is.
Yeah, so the traditional paradigm has always been to look at basically a timeline, and those patients who recur between 0 and 6 months were classified as platinum resistant. Those beyond 6 months, platinum sensitive, and we realize that a patient that's 5 months and a half is probably going to behave a little more like an intermediately platinum sensitive patient, a 6 to 12 month group. Or someone that's 6 months and a day is probably going to be very close to behaving like a platinum-resistant patient. So, you get into these gradations. And then we've really evolved, Brad. I mean, there's been a lot of translational science and everything else, and we're looking at molecular signatures that are unique to different histologies. And so we've really moved on to now looking at a multivariate approach. And so we look at the histology, the molecular signature that's there, such as BRCA and so forth. We also look at treatment-free interval, and I think number of lines of therapy is still important. And so consensus conferences now, they really, if you look at GCIG, most recent consensus conference, they've defined it into patients that are appropriate for platinum and those that are not appropriate for platinum. And that could be due to an allergy, it could be too many lines of therapy. You look at all those things
histology.
Together. Exactly.
I love it.
Yeah.
I'm going to say that again because I wrote it down as you said it. Number of lines of therapy, molecular signature, histologic type, and platinum-free interval. Thank you for that, and I'm grateful for your passion on that. So let's take a patient that would not be eligible for a platinum. What would be the standard single agents that would not be eligible for a platinum?
Well, so I think we certainly can look at things like liposomal doxorubicin, gemcitabine, topotecan, paclitaxel.
There you go. Weekly paclitaxel.
Exactly.
I like it.
And we can potentially add bevacizumab to those agents for even better outcomes.
So that was the first FDA-approved usage of bevacizumab, adding to those agents, not gemcitabine, but the other three in the Aurelia trial. And then, Michael, we had the GOG 213 in OCEANS as the platinum-sensitive 2016 opportunity. Tell me about OCEANS and 213 at a high level.
Yeah, so both were well-conducted large studies looking at the addition of bevacizumab to a platinum doublet, carboplatin gemcitabine for OCEANS and carboplatin and Taxol for 213, and both showed a remarkable similar result, I think, with a prolongation of PFS of about somewhere around 4 to 6 months. Again, somewhat reminiscent of 218, actually. There is some discussion, I'm sure you'll be invested in this, about whether there's actually an OS difference on 213. I'm not a particular believer on that, but the bottom line is Bev is active in that patient population. That led to the FDA approval.
Yeah,
for that,
right.
Right.
So, Krish, We have 3 PARP inhibitors now in platinum-sensitive maintenance. Just tell us what those agents are and what the label is for those.
So for women with, that are in need of second-line platinum therapy, they're platinum sensitive by the original definition, not the new paradigm, but more than 6 months, retreat with platinum, and if they respond, and it can be a partial or a complete response, those patients are eligible for any one of the 3 approved PARP inhibitors, olaparib, niraparib, or rucaparib.
So rucaparib, Ariel 3, olaparib, study 19, solo 2, okay, and then Ariel 3, rucaparib. Now,
Well, Nova for
Nova and niraparib, thank you. See, I can't keep it, there's so many opportunities. I understand how to treat patients, but the science.
But it brings up a very interesting new paradigm, because bevacizumab is also approved with chemotherapy in this recurrent population. So there's an opportunity, depending on how things go, tolerability levels, et cetera, to switch maintenance therapy to a PARP inhibitor once the patient has a partial or complete response. And in my practice, I don't go for the complete response unless they've had a very long platinum-free interval, because I may lose that opportunity to treat them with a PARP.
So Ariel 3, rucaparib, study 19, solo 2, olaparib, niraparib, Nova. Study 213, GOG 213 in Oceans. I got 5 trials. How many patients do you think are not getting maintenance? I mean, this should be a paradigm shift. I got 5 positive phase 3 trials that I can barely name. Do you think everyone's getting maintenance in platinum-sensitive relapsed ovarian cancer?
We don't really need to guess at that. I mean, there's some substantial data from Flatiron databases and other sources that suggest that the amount of patients getting maintenance is somewhere around 30%. I find that astonishing.
Astonishing.
It's a little bit higher in an abstract at ASCO 2019, but
So it's
your
creeping
point's
up.
still well taken. It's still under 50%.